So this morning I'll be presenting along with Dana Lin on a game-based virtual patient platform to assess surgical decision-making. First, I'll provide a background relevant to the serious game-based platform that we're presenting today, including an introduction to entrustable professional activities, our conceptual framework for assessment of EPAs, and the process for developing case content. And then I'll pass the presentation to Dana Lin, who will describe the development of the game platform, present a demo, and describe our plans for collection of validity, evidence, and scalability. What is an EPA? So this is a medical education concept that was developed in 2005 by Ole ten Cate, who is a PhD educator in the Netherlands. And it's essentially a unit of professional practice defined as tasks to be entrusted to the unsupervised trainee once he or she has attained a specific level of competence. And these are specialty specific, so the EPAs for surgery will be different than those for anesthesia or emergency medicine. They're meant to be independently executable, observable, and measurable. And this was first employed in medical education in a UME setting in the Netherlands, since has been applied to medical school setting in the US, and now more recently has been adopted in GME with the move towards competency-based residency education. So this brings us to the concept of entrustment, which is central to understanding EPAs. And essentially, faculty are already making daily ad hoc entrustment decisions with trainees based on past experience and personal observations, such as when you entrust your residents to perform bedside procedures or portions of operations. And essentially, entrustment occurs when a trainee has demonstrated the necessary knowledge, skills, and attitudes to be trusted to independently perform an activity. What EPAs do is they essentially formalize this process with objective criteria and define levels of entrustment, and this is helpful. It gives trainees a blueprint to understand specific behaviors that are necessary for entrustment. There are 5 EPA levels as defined by the American Board of Surgery. Level 1, observation only, followed by direct supervision, indirect supervision. This would mean not immediately supervising, but nearby, so in the room or in the hospital. Level 3 is termed unsupervised practice, but really what this means is distant supervision and oversight. So for example, supervising a resident from home. And then level 4 is resident supervising others, meaning taking juniors through cases or overseeing juniors. So the American Board of Surgery initiated a 2-year pilot program in 28 residency programs, which started in 2018 and will end next month. And they developed 5 initial general surgery EPAs, but recognized that ultimately general surgery would likely require 20 to 30 EPAs to capture what is necessary in training. And so these 5 are listed here, and Stanford is the pilot for 2 of these, inguinal hernia and gallbladder disease. And the American Board emphasized that assessment of EPAs should span the preoperative, intraoperative, and postoperative phases of care, but they were not prescriptive on how to do this, so they let individual institutions decide how to assess EPAs with no central toolbox. And at the end of each academic year, programs are asked to assign a level of 0 through 4 to each general surgery resident for each pilot EPA, as well as their confidence in that level assessment. The ABS formally defined each EPA. This is an example for the inguinal hernia. It was defined that the resident must be able to perform these behaviors, and as you can see, it ranges from diagnosis and complete pre-op evaluation to informed consent, performing the procedure, and overseeing the postoperative care and complications. Based on the need to comprehensively assess residents in these phases of care with each EPA, we developed a conceptual framework for the domains of entrustability and assessment of EPAs, and this was created in conjunction with Dana Lin and James Korndorfer. So in our conceptual framework, we state that there are 3 domains of entrustability, and this is clinical evaluation of the patient, technical skills, and clinical decision-making. And currently, many pilot programs are able to collect data on the intraoperative performance of residents using, for example, the Simple app. But there's an identified gap in the pilot programs in that they often do not have adequate data or tools to objectively measure the other phases of care and are also limited by the number of evaluations, in particular, difficulty assessing clinical decision-making. So we felt that each of these domains needs to be assessed for a trainee to be entrustable. and proposed the following framework for assessment. So for clinical evaluation, Dr. Natalie Krolchak has done work on the EPA pilot and is heading the EPA pilot at Stanford. So she's created a QR code on Qualtrics for the preoperative evaluation of patients. And we additionally created an observed clinical checklist that I'll show you shortly. For technical skills, Natalie Krolchak and James Korndorfer have implemented, as you've seen, the Qualtrics QR in inguinal hernia and lap chole codes, and also the simple app. And finally, we felt that the assessment of clinical or surgical decision-making was central to entrustment and found a need for a reproducible, objective way to assess this domain, and that's the primary focus of our presentation today. And underlying all of these is the existing direct observations from faculty and end-of-rotation evaluations, which span all three domains, but often they're not in sufficient granular detail to assess progress on an individual EPA, such as inguinal hernia or gallbladder. So to go through each of these in a little bit more detail, so for the clinical evaluation, this is the additional a screenshot of the checklist that we created. And this is an inguinal hernia EPA checklist. We used an electronic modified Delphi approach. Many of you were part of this. There were 13 faculty who perform inguinal hernia repair in various settings. And using this, we identified an objective assessment and checklist for junior residents to be able to take the history of, correctly examine, and consent a patient with inguinal hernia. And the intention of this is that it will be piloted at the VA, where we have a high volume of inguinal hernia patients, and standard setting will be used to determine cutoff scores for pass, fail, and for each EPA level. For technical skills, you may be familiar with this. So these are the existing tools that have been implemented for the assessment of technical skills. On the left is the Qualtrics QR code for inguinal hernia, but a similar one exists for cholecystectomy. And then on the right is the simple app. And finally, for the assessment of clinical decision-making, we propose the use of a serious game-based virtual platform that we're presenting today. And as you know, an operation is more than technical skills and dexterity, and an entrustable trainee must possess sound surgical decision-making. The goal of this platform was to focus on the critical decision-making that's not reliably observable with the existing assessment modalities, particularly the workup and management of emergent presentations, of intraoperative findings, and infrequent complications. To bring this all together, we've developed a model and proposed model for how this information could be used to assign EPA levels to trainees annually at a clinical competency committee meeting. Objective data from the clinical evaluation, the technical skills, and the clinical decision-making, as described previously, could be recorded in a streamlined numerical fashion and combined to assign each resident an inguinal hernia EPA level ranging from 0 to 4 each year. The goal would be to make this as automated as possible so that the score data from these assessments could be inputted into a spreadsheet, and then a tentative EPA level for each resident could be generated and reviewed by the CCC, with then faculty observations and end-of-rotation evaluations utilized to adjust this EPA level assignment where appropriate. This is an example of how this data could be visually displayed in a CCC and for individual residents to look at their progress. You can see on the left is an example of a resident who's underperforming in EPAs compared to their peers, particularly with regard to the trauma EPA. But in contrast, on the right, resident B is performing at the level of their peers in all EPAs. Now I'll shift to discussion of the process for developing the inguinal hernia case content for our platform. The American Board, a pilot, provided very detailed expected behaviors for residents, performance in the pre-op, in the intra-op, and the post-operative settings for each level from 0 to 4 for each of these 5 EPAs, and this is what's listed here is for inguinal hernia. And in addition to this, they also provided pilot programs with detailed descriptions of what a level 0, 1, 2, et cetera, resident would be able to do, as well as example vignettes for each level. To date, we've created 4 initial cases for the inguinal hernia EPA. And to do this, we aligned the case content with the American Board pilot using the definitions and descriptions I just showed. And additionally, we determined which clinical decision-making skills our local faculty felt were essential for a resident to be deemed entrustable in inguinal hernia, using a modified Delphi approach, and that was part of the project also that created the checklist. So this included 13 of our faculty in various practice settings. And we found excellent alignment between the American board definitions and our own local modified Delphi results. We then used this information to create the cases. These were written by the principal investigators. They incorporated multiple different settings, and this was an iterative process. We then held a consensus panel in December of 2019, including 5 of our faculty. They were general surgeons with and without fellowship training, ranging from assistant to full professor, and in various practice settings, and 3 of the 5 had formal training or leadership roles in surgical education. And the goal of this was to review and vet the cases prior to inputting them into the platform. Okay, so I'll now pass the presentation on to Dr. Dana Lin to describe the development of the platform.
Thank you, Cara. So traditionally, clinical decision-making in surgery has been formally assessed through in-person verbal interrogation via the oral boards. However, there are limitations to this assessment modality. It is time and resource intensive and vulnerable to subjectivity and bias. A game-based virtual patient platform offers an immersive and realistic environment in which trainees demonstrate their management of a given clinical scenario. It is objective in that it features standardized scenarios, it minimizes bias and subjectivity of faculty raters, and actually reduces the ever-increasing burden upon faculty to complete multiple, frequent, and timely evaluations of their trainees. It is reproducible, and moreover, it is less time and resource intensive than oral board questioning. It also has the ability to assess clinical judgment for rarely encountered yet critical scenarios. We initially sought out faculty from our computer science department at Stanford, but we referred over to UC Santa Cruz as it is one of the top ranked programs in the world for games and playable media and serious games. We formed a collaboration with Eddie Meltzer, a game developer and professor of computational media at UCSC, who has specific interest and expertise in educational games. With funding provided by the Division of General Surgery Seed Grant, he assembled a team of graduate students to bring this platform to life. Before I demo the platform, I'd like to briefly touch upon the technical specifications of the platform. It is essentially a web game that can be played on Chrome or Firefox. The program's Angular, Bootstrap, and Angular material were utilized to produce the front-end user face, including style, aesthetic, layout, interactive clicking, and logic. The backend data is stored on Firebase and Google Cloud Platform. These services allow the game to load different surgical cases and log player actions throughout the game. Figma and Adobe software allow for game assets to be produced and vetted by the team before implementing them. So what we have in this next video clip is a short demo of our platform. It will give you a sense of how the simulations are deployed and the basic functionality of the game platform. The platform is still in development, and we anticipate the full complement of inguinal hernia case scenarios to be polished and ready in early fall. We have provisionally named our platform Entrust. The game platform is divided into 2 basic modes, a clinical mode and an OR mode. The patient scenarios begin in a pre-operative clinical setting, either inpatient or outpatient, where the player initiates workup of the patient. To orient you to the game layout, the patient's chart is located on the right side of the screen. The front page provides a brief clinical vignette. In this case scenario, a patient presents with a small bowel obstruction secondary to an incarcerated inguinal hernia. A visual of the patient is depicted on the left side of the screen. The patient's vital signs appear in the central upper area and reflect the clinical status of the patient. The vital signs will deteriorate over time, but can change based on interventions performed, such as giving an IV fluid bolus. To examine the patient, you can hover over and click on regions of the body to elicit physical exam findings. As you do so, the findings will appear under the physical exam section of the patient's chart. Here, the patient's groin exam reveals a firm, tender bulge in the right groin with overlying erythema. After examination of the groin, a clinical decision-making question pops up. We are asked whether we should attempt to reduce the hernia by the bedside. The action buttons to work up and treat the patient are located on this computer monitor in the middle of the screen. You can order labs or imaging studies. For example, in this patient, we will want a CBC, a BNP, and a lactate. As for imaging, we might want an abdominal series and a CT scan of the abdomen and pelvis. Once you select a test or intervention, the status of the order can be tracked on this in-progress screen. Results can be accessed via the corresponding tabs in the patient chart. Under interventions, we can order an IV fluid bolus as the patient is becoming hypotensive and tachycardic. In addition, you can transfuse blood, administer antibiotics, or perform bedside procedures such as insert an NG2 with Foley catheter. In checking our labs, we note that the patient has an elevated white count and lactate. Under imaging, a representative key image is provided, which we must interpret correctly in order to arrive at the diagnosis. Here we see a right-sided inguinal hernia with multiple proximal dilated loops of bowel. The bowel within the hernia sac appears thickened with fluid around it, suggestive of ischemia. Once we are satisfied with the workup and confident of the diagnosis, we can proceed to the operating room, which is signified by this button with a scalpel icon. This will transport us into the OR mode, where we must answer a series of multiple choice surgical decision-making questions, from what operation you would perform, to where you will make the incision, to what you would do if you were presented with certain findings in the operating room. As you can see from the score icon in the top left, the player will gain points for answering correctly and lose points for answering incorrectly. Once the scenario has concluded, we can proceed to the next case.
So in terms of scoring, actions within the pre-play mode is recorded and timestamped. Players earn points for ordering relevant labs and key interventions. Conversely, they will lose points for performing inappropriate, unnecessary, or harmful actions. Some choices are graded as neutral. No points will be gained or lost. As for the decision-making questions in the OR mode, players are awarded points if they select the correct answer, knowing that there may be more than one reasonable or correct answer choice for a given question. Critical and correct maneuvers and actions were determined as such by expert consensus through the modified Delphi process that Cara described. The platform is primarily designed as an assessment platform in which no score counter is visible. Rather, the points are tallied from the back end. However, to make it flexible as a platform, we did build a learning mode where a score counter can be displayed in order to promote engagement and provide immediate feedback. The virtual platform will feature an authoring portal by which faculty and educators can create customized case-based assessment scenarios for other clinical domains and learner populations. In this way, the platform is adaptable and scalable and can be utilized by other training programs and medical specialties. It could even be a vehicle for accrediting bodies for undergraduate and graduate medical education to deliver standardized high-stakes assessments in the future. Here is a sneak peek of the authoring capabilities of the platform. The goal is for it to be a user-friendly interface that allows content experts without any computer programming background to directly create case scenarios and deploy them on the platform. Authors will have the ability to input case stems, lab values, diagnostic images, and decision-making questions, as well as ascribe point values to various actions and question choices. Patient graphics can be tailored to reflect the age, ethnicity, body habitus, and physical findings of the patient. The data collected from the back end will be able to provide individualized performance feedback as well as aggregate user data that will be instrumental for collecting validity evidence and standard setting. In our pilot, the players will be asked to complete brief demographic survey which queries information such as age, gender, level of training, specialty, and such. In terms of gameplay variables, the following data will be collected: total score, subscores, timestamps of all actions, time in free play mode, and responses to questions in the OR and question mode. Our research aim is to collect validity evidence for the inguinal hernia assessment as a potential high-stakes summative assessment using Messick's framework for validity. Based on our sample size calculations, we estimate we will need a total of 150 participants of various levels of training to complete the virtual patient assessment. We will initially pilot the platform among medical students, general surgery residents, and surgical faculty at Stanford. We then plan to expand this nationally. Initially, our plan was to set up a booth at a national surgical meeting and recruit trainees and surgeons to participate. Now, given the uncertainty of future large gatherings in light of the pandemic, we may forge collaborations with other EPA pilot institutions to deploy the platform among their residents and faculty. The beauty of it being a digital virtual platform is that it can be accessed anywhere at any time. Content validity of the scenarios was already discussed at length during Cara's portion of the presentation. We will be performing psychometric analysis of the multiple choice questions. Specifically, we will be looking at the following metrics: item difficulty, item discrimination, standard error of measurement, and reliability. We will build construct validity evidence by conducting bivariate and multivariate analyses to measure associations between total score and other demographic and performance metrics such as level of training, numbers of procedures performed, ABSITE scores, American Board of Surgery qualifying and certifying exam results, and the Qualtrics EPA OR app ratings for inguinal hernia. We will calculate population estimates for the purpose of benchmarking performance as first steps towards distinguishing levels of entrustability and ultimately deriving a cut score that signifies practice readiness and entrustment in the domain of inguinal hernia. We are excited about the possibility of mapping out gameplay patterns to see if we can differentiate experts versus less experienced individuals. This would be the equivalent of economy of motion metric that we talk about when we talk about technical skill. Skilled surgeons utilize the minimal amount of movement necessary to accomplish a task, maximizing time and efficiency. Novices, however, may arrive at the same outcome, but do so by using wide, flailing, and unnecessary movements. This concept can be similarly translated to gameplay. In the above example, player A progresses through the task, starting at the red dot and ending at the blue dot in a tight sequential fashion. Player B, on the other hand, makes multiple errors, requiring many instances of backtracking before arriving at the endpoint. At this point, we have developed a collection of cases for inguinal hernia, the EPA domain of inguinal hernia. In terms of next steps, we plan to develop case scenarios for the other core general surgery EPAs using the same robust workflow that we used for creating the inguinal hernia case. The platform, being as flexible as it is, can be utilized for other learner populations such as medical students, fellows, and even allied health professionals to assess competencies related to their learning goals and objectives. Moreover, we foresee applications in other surgical subspecialties and even non-surgical subspecialties such as anesthesia and emergency medicine. I would like to acknowledge and extend a big thank you to Dr. Eddie Melser, our co-principal investigator at UC Santa Cruz, for leading his group of brilliant engineers and designers in making the Entrust platform a reality. And also a special thanks to Sylvia Breckney-Morel and Amber Trickey of Aspire for their invaluable assistance in development of our research design and analytics strategy. I would also like to thank the leadership of the Department of Surgery, Division of General Surgery, the General Surgery Residency Program, Aspire, and the Goodman Surgical Education Center for their support of our work. This would not be possible without funding from the Stanford General Surgery Division C grant. I'm also very pleased to share that we were awarded the Association for Program Directors in Surgery 2020 Research Grant to further propel this project forward. We look forward to presenting our pilot data to the department sometime next year. Thank you.